Okay, Assalamu alaikum. Today we'll talk about bronchopulmonary dysplasia. Okay, our objective it was introduction about the bronchopulmonary dysplasia, definition and new form, classical definition and new form of bronchopulmonary dysplasia, and also pathology and pathogenesis of bronchopulmonary dysplasia and guideline for management of bronchopulmonary dysplasia and new treatments for bronchopulmonary dysplasia and prevention. As we know, bronchopulmonary dysplasia is the most common chronic lung disease in infants and associated with increasing mortality, respiratory morbidity, and neurodevelopmental impairment and increasing healthcare cost. Bronchopulmonary dysplasia, it is actually affecting up to 45% of infants born less than 29 weeks of gestational age. Bronchopulmonary dysplasia also is not a lung disease only, but it's a systemic condition with lifelong implication for adult health and quality of life. We have classical bronchopulmonary dysplasia, which was first described in 1967 by Northway. Their cohort was including term and preterm infant who survived high-lyme membrane disease, exposed to high ventilatory pressure and oxygen concentration. From this time, we started to have the first definition for bronchopulmonary dysplasia. The disease was characterized by cystic emphysema and fibrosis on chest X-ray. On lung histology was interstitial and alveolar edema and small airway disease, inflammation and fibrosis. Following the significant advance in NICU in the last 50 years, which is including introduction of antenatal steroids, surfactant, more gentle ventilation, and critical use of oxygen, this led to the characteristic of classic bronchopulmonary dysplasia have changed to new form of bronchopulmonary dysplasia. As we see here, we have different definition and modification for the bronchopulmonary dysplasia. Started from first definition from 1967 until the ended by 2018 and 2019 modification, which is defined the bronchopulmonary dysplasia needing for oxygen more than 28 days of life, with assessment at age of 36 weeks, and classified bronchopulmonary dysplasia to 3 grades. Grade 1 was needing of the oxygen more than 21%. Grade 2 more than 30%. Grade 3 F invasive mechanical ventilation. Then in 2019, they are changing the definition or actually modifying the definition to be according to the respiratory support, because they are finding the morbidity and mortality of the disease. It is not depending on only flow of the oxygen as a percentage, but also depending on the type of respiratory support they are receiving the child. So it became grade 1, grade 2, grade 3. Grade 1 with nasal cannula and flow rate less than 2 liter. Grade 2 with nasal cannula, flow rate more than 2 liter, or CPAP or non-invasive. And grade 3, it became as invasive mechanical ventilation. Here we have some of the factors and pathogenesis which can lead to bronchopulmonary dysplasia. We have factor during the prenatal period, and we have factor postnatal during the early and evolving phases. The prenatal period, when we have a placental insufficiency, we will have impaired vascular development, which will lead also to impaired pulmonary development. When we have prematurity, we will have impaired pulmonary development. And also, if we have altered in immune development during the prenatal period, which will lead to a genetic predisposition, also will lead to some factor increase bronchopulmonary dysplasia. But if we have altered immune development, we will increase the risk of neck, increase the risk in neck, it will lead to inflammation. Inflammation will lead to impaired pulmonary alveolar and vascular development. And also postnatal, if we have an infection with increased risk of inflammation, if we have supplemental oxygen and invasive positive pressure ventilation will lead to tissue damage will lead to same impaired in the pulmonary alveolar vascular development. We have some factor, it will enhance a lung development like breast milk. Breast milk, they have favorable microbiome, and also vitamin D administration will enhance cell growth and repair, and also high energy will enhance cell growth and repair. Here is the pathogenesis of new. This picture is showing the pathogenesis of new and old bronchopulmonary dysplasia. We will start from the old bronchopulmonary dysplasia, which is usually they are prescribing the postnatal exposure of ventilatory-induced lung injury, oxidative stress, infection, steroid, pulmonary fluid overload, and nutritional deficit all lead to structure and inflammation, structure injury and inflammation, with normal development of the lung. The new definition of the new BPD, it is usually due to developmental arrest and delay of the lung development, which is usually from the canalicularis stage through the sacral stage, which is some antenatal exposure, steroids, cardiomyelitis, and IUGR, genetic susceptibility, all it will increase the new BPD risk factors. New form of bronchopulmonary dysplasia, it is first described in 1999 by Alan Job, which is coined the term of new bronchopulmonary dysplasia to describe a pattern of decreased alveolarization and pulmonary vasculature with less inflammation and fibrosis and minimal airway disease. New bronchopulmonary dysplasia developed with increased survival of extremely preterm infant from 22 to 25 weeks of gestation and in advanced neonatal care. The new bronchopulmonary dysplasia is associated with arrest in the pulmonary development, and this arrest in pulmonary development usually occurs in the preterm infant, only during the late canalicularis stage through the sacral stage of lung development. The arrest in lung development may be due to early exposure of immature lung to breathing in a gas environment, or an effect of oxygen toxicity and bowel trauma. Here we have a comparison between the classic and new bronchopulmonary dysplasia. Classic bronchopulmonary dysplasia, it is usually for premature and term infant before the steroid and surfactant era. A short period of high ventilatory support, which leading sometimes to paro and bowel trauma, hyperventilation with normal to low CO2, associated with pulmonary air leaks, meconium aspiration syndrome, and pneumonia, and characterized by inflammation, fibrosis, and area of atelectasis, and alternating with area of emphysema on chest X-ray. Usually we are seeing this picture, and injury and repair sequence. But in new bronchopulmonary dysplasia, usually in very low pulse weight, extreme low pulse weight infant with modest ventilatory support over muscles, permissive hypercapnia, but inability to wean off the assisted ventilation, associated with risk of cardiomyelitis, sepsis, BDA, poor nutrition, vitamin deficiencies, especially vitamin A, which is responsible for the lung development. Less prominent inflammation and fibrosis in the histology, and dilated alveolar duct. Maldevelopment sequence, which lead to alveolar septation and alveolar surface area and decreased alveolar surface area and decreased microvascular development. Here we have a histology of the old BPD and new BPD. As we said, old BPD, it is usually characterized by inflammation, fibrosis due to the mechanical ventilation and toxicity. But new BPD, it is arrest in the lung development, which is characterized by decreased precipitation and alveolar hypoplasia, which leading to fewer and larger alveoli, so less surface area for gas exchange. With this regulation of the vascular development, leading to abnormal distribution of alveolar capillary and thickened muscular layer of pulmonary arterioles. Here we have different chest X-ray for the old BPD and new BPD. Old BPD, usually they are characterized by cystic itches, atelectasis area with emphysema. New BPD, uniform inflation, less fibrosis, absence of absence of emphysema or fibrosis, and regarding the pathology, hallmark is larger simplified alveoli and dysmorphic pulmonary vasculature, as we see in the histology picture. Here we have the management of bronchopulmonary dysplasia according to the British Medical Journal. The guideline for management of bronchopulmonary dysplasia by British Medical Journal, they are dividing the guideline management according to the phase. First phase, it is the early phase, which is less than 1 week. Starting by oxygen supplementation, supposed to maintain the oxygen saturation from 90 to 95 to decrease the risk of toxicity. Ventilatory strategy, trial of CPAP for spontaneous breathing infant, consider surfactant administration if I2 remain constant more than 40% on PEEP 6. Using administration of surfactant with less invasive route like inshore or laser. Consider volume targeted ventilation strategy with tidal volume from 4 to 6 ml per kg, using short inspirator time in 0.3 to 0.4, rapid rate, low PIP pressure with from 14 to 20, moderate PEEP from 4 to 6, and oxygen from 40, and consider oxygen being from 40 to 60 and CO2 from 45 to 55. And we have to suppose trial of extubation to non-invasive before 7 days in infant who tolerate weaning to minimal setting. Starting early administration of caffeine in first 3 days of life to decrease the risk of bronchopulmonary dysplasia. And there is some evidence of intratracheal administration of budesonide and surfactant, which can lead to decrease bronchopulmonary dysplasia-free survival. The study to date not adequately powered to assess the long-term neurodevelopmental outcome, but actually I have one study showing there is no any neurodevelopmental side effect up to 2 years of age. And also administration of vitamin A, as we said, it is enhanced lung development, improved also bronchopulmonary dysplasia-free survival with reported number need to treat from 14 to 15, with dose 5,000 international unit, giving intramuscular 3 times a week for 4 weeks. Also, there is a trial of low-dose hydrocortisone is associated with increased bronchopulmonary dysplasia-free survival, but it actually, unfortunately, increases the risk of late onset sepsis in infant less than 26 weeks, increase the risk of SEP, spontaneous intestinal perforation, and infant who receive endomycin. Restrictive fluid intake may decrease the bronchopulmonary dysplasia, but actually there is no any evidence for that. Nutrition, exclusive human milk feeding reduces the risk of bronchopulmonary dysplasia, as we see it is contains some of microbiome, which is promote lung development. Here we have the guideline management for the second phase, evolving phase, which is more than 1 week of life up to 36 weeks before the established area. We have 3 phases: early phase, evolving phase, established phase. Evolving phase from day 7 to 36 weeks. They are giving dexamethasone. Low dexamethasone facilitates extubation but doesn't reduce the bronchopulmonary dysplasia. High dexamethasone, it is associated with increased risk of neurodevelopmental impairment and CP. And regarding the ventilatory strategy, we suppose to avoid the endotracheal tube ventilation, encourage non-invasive support strategy during this stage if we need to respiratory support. And we have to keep the patient with permissive hypercapnia from 50 to 60, and oxygen from 50 to 70, and with pH 7.25. Regarding diuretics, actually still there is no any evidence, but still they are using, may improve respiratory mechanics and facilitate the weaning of support, but don't prevent bronchopulmonary dysplasia, and continue use only if clear response demonstrated. Nutrition, same as the early phase, and caffeine and mesalazine, same as early phase. Established phase, this is the age of assessment, 36 weeks and above. This is at the time we can say this baby is having bronchopulmonary dysplasia, established phase. We have to screen this baby for resistant pulmonary hypertension, as more than 25% with moderate to severe bronchopulmonary dysplasia, they have evidence of pulmonary hypertension. Bronchodilator may improve the symptom in subpopulation of affected infant. Inhaled steroid Later use may improve the symptom in subpopulation of infant. Diuretics, chronic therapy as for the evolving phase, consider allowing the infant to outgrow of this dose. Regarding nutrition and immunization in this, nutrition same as early phase and evolving phase, but avoid excessive weight gain. Immunization, we have to give them prophylaxis against the RSV, influenza, which is decrease rehospitalization and morbidity. Here we have the criteria for discharging this baby home and the use of oxygen in weaning process. First, we have to have absence of apnea, stabilized or regressed ROP to decide to discharge this baby. The gross it's supposed to be they have at least weight gain 20 grams per day. Immunization to complete as appropriate for postnatal age, receiving the first dose of RSV prophylaxis if appropriate. A flow rate is supposed to be stable for at least for 1 week on flow rate from 1 to 2 liters per minute on FI2 100 on maintaining saturation more than 92. Home monitoring, you have to learn the family and support them how to use the oxygen, how to support them by teaching, and how they are monitoring the baby at home. Criteria for home oxygen use. Usually you have to have follow-up for this baby every 4 weeks or sooner if need. The weaning process, we have to learn the family how to wean, usually weaning from 0.25 to 1. If the target oxygen more than 92 or more than 96, consider slow weaning if the bronchopulmonary dysplasia associated with pulmonary hypertension. Consider not weaning the baby if the growth is inadequate. Wean to room air when he is awake first, then after that during the sleep. We have to do overnight oximetry test if the oxygen saturation more than 90. For 98 time of the study, we can at that time wean to the room air. And if it's stable in room air, we have to keep the oxygen also cylinder and pulse oximeter at home at least for 3 months to allow to be available during the acute deterioration, especially if the baby was having any upper respiratory tract infection. Here we have the evidence-based to bronchopulmonary treatment. We will start by okay. We'll start by corticosteroid and bronchopulmonary dysplasia. First by antenatal corticosteroid. And 2017 Cochrane review of 30 study, which is include 8,058 infants, showed that antenatal corticosteroid administration reducing the overall mortality and respiratory need for respiratory support, intraventricular hemorrhage, and neck. But the evidence of effect for reducing bronchopulmonary dysplasia was less clear due to wide confidence interval, as many included study didn't report this outcome. And here we have the high evidence for decreasing perinatal deaths, neonatal deaths, respiratory distress syndrome, and intraventricular hemorrhage. Postnatal corticosteroid, because as we know, the inflammation play a very important role and part of pathogenesis of bronchopulmonary dysplasia. It was hoped that the corticosteroid administered postnatally might reduce the lung injury and bronchopulmonary dysplasia. We have different routes. We have inhaled corticosteroid, which is given early and late. We have intratracheal administration of corticosteroid, and we have systemic corticosteroid early and late. Here's the evidence of early systemic postnatal corticosteroid for preventing bronchopulmonary dysplasia in Cochrane reviews. That is, the early systemic corticosteroid show overall reduced and combined outcome of mortality or bronchopulmonary dysplasia at 36 weeks post-menstrual age. And the early systemic corticosteroid showed overall increase, unfortunately, with reducing the combined outcome of bronchopulmonary dysplasia and mortality, but associated with increased gastrointestinal perforation and also associated with increased cerebral palsy, especially with high dose dexamethasone in early life, less than 7 days of life. Here we have a study of early to low dose of hydrocortisone with for bronchopulmonary bronchopulmonary dysplasia, which shows that the early systemic hydrocortisone in the preterm infant is effective in increasing the chance of survival without bronchopulmonary dysplasia at age of 36 weeks post-menstrual age. But it is increased the risk of GI perforation, mostly if conjugation with early treatment for PDA, and increase the risk of late onset sepsis, especially for less than 25 weeks of gestational age. Here we have the evidence of an early low-dose hydrocortisone to safe for neurodevelopment. That is, the early dose hydrocortisone was associated with significant improvement in the neurodevelopment outcome in infant born at 24 to 25 weeks of gestation, as comparison by dexamethasone, which can cause impaired neurodevelopment and cerebral palsy. Here we have the evidence of administration of late systemic postnatal corticosteroid for preventing bronchopulmonary dysplasia. That is, the late systemic postnatal corticosteroid treatment reduces the risk of mortality in bronchopulmonary dysplasia and the combined outcome of mortality or bronchopulmonary dysplasia without evidence of increased cerebral palsy. This review supports the use of late systemic corticosteroid for infants who cannot be weaned from the mechanical ventilation, and the role of late systemic corticosteroid for infants who are not intubated still is unclear and need further investigation. Here's the risk summary of the effect of systemic glucocorticoid. Here, this is the route of inhalation of corticosteroid, and the question was, is early inhaled corticosteroid could be prevent the bronchopulmonary dysplasia in just two studies, showing that the death of bronchopulmonary dysplasia reduced in the infant who received Budesonide, 40% versus 46% in the placebo group. Survival without bronchopulmonary dysplasia was higher in the infant who received Budesonide, 27.8% versus 38%, with significant p-value. But there were more deaths in the Budesonide group than the placebo group, which was 16.9 versus 15.8, but actually it was not statistically significant. Here we have a Cochrane review regarding the inhalation of corticosteroid for bronchopulmonary dysplasia. The meta-analysis of the study showed that a reduced risk favors the inhalation of steroid regarding the failure of extubate at 7 days. And based on this result, currently available evidence of inhalation corticosteroid initiated at more than 7 days of life for preterm infants are at higher risk for developing bronchopulmonary dysplasia cannot be recommended at this point in time. Here we have the late inhaled corticosteroid, which is more and larger randomized and placebo-controlled trials are needed to establish the efficacy and safety of the inhalation of corticosteroid, because still it is not recommended at this time. It's the same slide. Here is the administration of intratracheal administration of budesonide with the surfactant to prevent bronchopulmonary dysplasia in very low birth weight. They found in this study the interventional group has significant lower incidence of bronchopulmonary dysplasia or death, 42% versus 66% with significant p-value during this intervention. But it is the intervention group have required significant fewer doses of surfactant than the control group, and the interventional group has significant lower of interleukin level, which is mean less inflammation, which is the main cause of the new BPD in the tracheal aspirate at age of 12 hours. Here we have the emergent treatment and new treatment. We have that is the antenatal N-acetylcysteine can be still studied under study. Antenatal N-acetylcysteine to improve the outcome of premature infant with interimmunotic infection, III, inflammation infection, randomized clinical trial. Placebo at the phase 1 placebo-controlled RCT of N-acetylcysteine administration in the woman presenting in preterm labor with confirmed intrauterine infection or inflammation showed there is dramatic reduction in the incidence of bronchopulmonary dysplasia in infant born to mother in the treatment group. It's still a study not published for. The other line of treatment they are starting. This is also a growth factor. There is found deficiency in insulin-like growth factor have been shown to be linked with the pathogenesis of bronchopulmonary dysplasia. And this study is phase 2 clinical trial designed to evaluate safety and efficacy of recombinant human insulin growth factor 1 complex in prevention ROP, and there is statistically significant decrease in the incidence of bronchopulmonary dysplasia with significant B value. Here we have the preventive measure of bronchopulmonary dysplasia. Optimal oxygen saturation, we have to have non-invasive ventilation, prophylactic surfactant, less invasive route for surfactant administration of early caffeine, possibility of azithromycin in subpopulation, and vitamin E administration. Here we have that is this is a meta-analysis, systematic review and meta-analysis done in Saudi Arabia and King Khalid University of Noura. There was doing assessment for azithromycin could be preventing bronchopulmonary dysplasia in preterm. Actually, it's showing that there's low quality evidence suggesting azithromycin therapy reduce bronchopulmonary dysplasia or death for preterm infant with positive urea plasma infection, but not in all preterm infants. Here we have the vitamin A supplementation. As we know, the vitamin A is involved in the growth and differentiation of many cells, including the epithelial cells of the respiratory tract, like other fat-soluble vitamin. It mostly accurate in fetus during the third trimester and preterm have been shown that the B vitamin D deficient lead to a risk factor for bronchopulmonary dysplasia. In Cochrane systemic review examining RCT trials of vitamin E supplement versus placebo included 11 trials with 1,460 infants. There was small reduction in the risk of bronchopulmonary dysplasia and death with no long-term adverse outcome. And something what's important that is repeated intramuscular injection required of vitamin A, and which were noted to be painful. Here we have the fluid restriction, evidence of fluid restriction and diuretic from the Cochrane review. Actually, fluid restriction and diuretic was found in the old bronchopulmonary dysplasia. Were noted to have generalized, and because as we said, all bronchopulmonary dysplasia have generalized and pulmonary edema associated with increased respiratory support requirement. But actually, using a new BPD, it is not clear whether association with the era of new BPD, which is delayed in the lung development and delayed alveolization rather than inflammatory edema. But in 2017, Cochrane review identified only one prospective trial of fluid restriction for infant was developing bronchopulmonary dysplasia. The infant was more than 28 days with persistent oxygen requirement, were randomized to either 145 ml per kg per day or 180 ml per kg per day of enteral feed. There were no important difference in any reported outcome, including mortality rate and severity of bronchopulmonary dysplasia at the age of 36 weeks. And also we have a potential risk of diuretics, plus there's no evidence that is we have risk of hyponatremia, hypokalemia, increased calcium loss, hypochloremic metabolic alkalosis, and the long-term effect on the bone growth and mineralization. And also some studies are showing that the Lasix can also stimulate renal prostaglandin production, which has may promote patency of BDA. Here we have the Canadian guideline for prevention bronchopulmonary dysplasia. Guideline for prevention bronchopulmonary dysplasia and assessment of the evolving bronchopulmonary dysplasia by Toronto Center for Neonatal Health. Target population was a neonate born less than 30 weeks of gestational age. Starting from non-invasive monitoring, targeting the oxygen from 90 to 95, using non-invasive CO2 monitoring for mechanical ventilated infant, surfactant administration, early selective surfactant administration for this infant requiring intubation, and for infant on CPAP during transition, first 2 hours to extra line of life, who have worsening or respiratory distress or requiring oxygen more than 30%. Recommending on optimized non-invasive CPAP and recommended intubation and surfactant administration as early as possible. Use of natural surfactant is preferred due to it is superior for effectiveness. Starting early caffeine, start caffeine on day 1 of life for infant at high risk for needing mechanical ventilation or non-invasive respiratory support. Regarding conventional ventilation, we have to initial mode of ventilation for infant born more than or equal to 27 weeks using targeted ventilation to protect the lung from the injury by providing from 4 to 6 ml per kg for volume targeted ventilation, and initial use of minimum PEEP of 5, and then advanced PEEP if required. Targeted adequate recruitment to avoid atlectic trauma while avoiding overdistension. And consider high-frequency oscillation ventilation or high-frequency jet ventilation for infants who require increase the PIP or increase the PEEP to achieve the targeted volume. Strongly considered initial mode of ventilation for infants high-frequency oscillation test. Strongly considered as initial mode of ventilation for infant born less than 27 weeks of gestation. Recommended high-frequency oscillation ventilation volume targeted mode with targeted volume from 1 to 2 ml per kg, starting by MAP 2 cm above the conventional ventilation, with frequency 8 to 10, with obtaining chest X-ray to assess the adequate aeration. Regarding the extubation, an infant was born less than 24 weeks of gestation. They have to be intubated to provide invasive ventilation for at least 72 hours, then extubate as soon as possible. Infant who born greater than or equal 24 weeks of gestation, you have to extubate as soon as possible to reduce further ventilatory-induced lung injury. Extubate to non-invasive respiratory support to maintain distended pressure on non-invasive mechanical ventilation. Then consider we don't have to consider extubation if we have blood gas are acceptable in low ventilatory setting. What is this low ventilatory setting? When he was on high frequency with MAB less than 11 or conventional mechanical ventilation from 8 to 9, FI2 less than 40% with good respiratory drive is adequate. Thank you. Any question?